Okay, so DENTA4 and real life application. Ultimately, we have all sorts of cases that come in and that require new VDOs. Now, this happens to be a case that's going to be an immediate denture on the upper, and on the lower, we've had instruction that this will be an acrylic partial. Okay, now this patient, when I show you the actual bite, you're going to identify really, really quickly that this patient will require a opening, and I'll show you where I'm going here. I want to start first of all and talk about how we get a level plane of occlusion. Okay, how we build that. Excuse me. So we got here a nice level table. This is the Aculine articulator. Now, unfortunately, in the impression, we did not get really accurate hamular notches back here. So we weren't able to actually hamular notch incisal papilla mount this case. So we had to resort to the picture to make sure that we had a very close to accurate horizontal, okay? But the wild card was the pitch, okay? The pitch being this of the maxillary. Now, fortunately, we got a cuspid, a bi, and a destroyed molar back there that's off the table. But you can see how they line up, the two canines, very, very closely. And now we've got something to work with. And this is for an immediate denture. Pictures will pop up of this so you can see what the patient looks like. And we pretty much have established that a 11 mil central will actually look really good on this patient. And we'll build that to this table, okay? So if you have a look there, it actually shows 11 mils to the table. We may shorten that slightly to 10, but that's an easy chair side adjustment to make it shorter, not longer. But we want to build a level plane of occlusion. And Dr. Carlson, back in the day when Dr. James Carlson explained to us, the key to success with occlusion, you number one got to have a level plane of occlusion, and number two, to establish where that level plane actually is, you want to find out where the F point is, which is the incisal edge position of the centrals and or midline. So if you look right here, it lines right up with this little indicator, and ultimately that's what we're looking to figure out. And then we build a level plane of occlusion back from there with a compensating curve. Very, very important, just like everyone's been taught in dental school. So once we establish that level plane, keying off of the F point, which is, we made a beautiful little chart here for these kind of cases. You'll see right here, this is how we describe the F point. It's an XYZ point, which means anterior posterior, incisal length, and or left or right. And in order for us to really figure out what that is, we need these 4 picture protocols, because ultimately we want to see what the nice natural face looks like in analyzing how the smile line is. We want to see what the occlusion is by retracting it. And more importantly, from these images, we want to make sure the pupil plane is level with the occlusal plane. And then, of course, the EMMA, most doctors and or techs aren't aware how key that is. On a man, normally you'll have 1 to 2 millimeters display, pronouncing EMMA, or less, but 1 to 2 looks natural. On a lady, it's 2 to 3, sometimes more, depending on the youthfulness or the physiology. And now this E picture is the next most important picture everyone needs to take. And for some, it seems obvious, but not everyone. But techs usually never get this picture. And why it's important is we need to see how critical the gingival third of the teeth are. If we're doing implant work, we need to see how the gum architecture is, that it's complementing. If you have a super low lip line, then it's not a big, we don't have to be as critical. But if you've got a patient that flashes an E that high, everyone, dentist and or tech, better be on red alert to nail this, because it will stick out like a sore thumb if you don't have a nice transition. And then you're going one step forward and 2 steps back, trying to explain to the patient after the fact that your crown doesn't look as good as it should, or the gum lines aren't architectured properly. But if you handle that out of the gate, right out of the beginning, then you know it's been dealt with. It's not a reactionary thing if it's not to the patient's expectations. So once we establish this F point, now we build a nice occlusal plane. This happens to be for a denture application, but ultimately we want an occlusal plane that basically complements this F point. Okay, so now that we've determined that, I made these little quick jigs just as an estimation to see where we are at. And you'll see, I'll just put these in here quickly and get that set in here. So that one, and then this guy. So this is just an eyeball guesstimation of where this where the new occlusal plane will be. Okay, this is not an exact science, but as technicians, when we're engineering stuff and trying to figure out where the goalposts are, we now know that this is relatively a close occlusal plane. And now we're going to see how it matches up with the bite. So on the lower, the doctor is going to preserve these teeth, okay, from the 4-4 to the 3-3. And these are all getting extracted. They're all bombed out teeth anyways. You can kind of see here, this was before I extracted them. It's just the teeth are not salvageable. So, and this is important too, especially for periodontists that are setting up cases, doing implant planning. Occlusion is going to be the long-term success of these cases. If this isn't planned out properly ahead of time, everyone's reactionary to wherever the implants are. So when we know where the occlusion is going to be, it makes it a lot easier. So now, if you have a look here, I haven't even actually closed down to the bite, to the patient's centric, or let's just call it his bite, okay? It's not centric occlusion. It's not really CO because he doesn't really have a bite. But if I want to level these things off, you can already see I'm hitting on the retromolar pad area and or this tooth. So where I'm going with this patient, anyone that has a bite, and just looking at teeth that are this is what the patient's bite actually is. Anyone who has a bite like that, I'm going to ask yourself, do you think that this bite is a condylar position that's healthy, like true centric or a CR? Or do you think it's some hybrid of this, where the condyl's upwardmost, backwardmost, and likely the disc is in an unfavorable position? My estimation is, just doing this as long as I had, and with docs that have the ability to do CBCT scans and or x-rays, these patients are upward, backward most. Whether they have a click or not, or deviation or deflection is, depending on age and how bad it is. But anytime dentition is, or this vertical is that closed, that condyle only has one place to go, and that's upward most, backward most. So for us to just open this on a hinge articulator, to open it up, is absolutely crazy. We just would never do that. It's not going to give you the patient the results they're looking for. So what our suggestion is, and this is what we like to help doctors with this learning curve, is first build a nice level plane of occlusion. Now we're just setting this case up, and do an immediate denture on a case like this first, before implants, before dialing in the bite. Get the upper set up to so it aesthetically looks good, and it's engineered to complement the angulation of the condylar fossa. And because we know for a fact, if a patient has a steep eminence of a condylar fossa, they can get away with an overbite, okay? Because they open and close like a rabbit. But if that patient has a flat eminence and you have designed the incorrect occlusion, you're going to break teeth, you're going to displace dentures, and you're going to create problems for implants down the road. You have to match the occlusion to complement the condylar eminence. And this is a nice illustration here. If we just have a look, and this is textbook stuff. This is not, but it's with application. So if you have a steep, let's use this as an example, you can get away with a 2 millimeter overbite. If you have moderate angle of eminence, which is what most patients are, we kind of presume it's around 60 to 80% are this. You can get away with a 1 millimeter overbite. But here's the trap. If you assume, and you got patient that has ground down dentition, like I hate to say it, like a cow dentition, where you have 0 overbite, and they're likely going to be a shallow eminence. Now, if you all of a sudden in your, because of the request of the patient, they want to, lengthen the length of their teeth or open up the occlusion for whatever restorative reason, and you make any kind of either steep or moderate overbite on your setup, you will bust teeth if you have a patient that has a shallower eminence. So it's very, very important to really assess these things, and that's why we made this little cheat sheet for you to give us the right information. We need the pictures. It's nice to have. We realize you can't always get it, but if we discuss and at least aware of what we're looking for, either moderate, steep, or shallow, this will determine what kind of occlusion we set up. And then last but not least, that's how we then determine with these pictures what is the best F point for this patient. Okay, so that's what I just wanted to go over with this illustration. The next thing that I'm going to propose to the doctor here is we're going to do an immediate denture, keying off of these teeth and or the F point that complements the length of these teeth, and build it to a nice level plane of occlusion, then give a patient a hard pivot orthotic for the lower to chew and function on and reestablish this new optimal vertical dimension, and then get them into a position where they have room back there, because I think every dentist and or periodontist and or surgeon will agree this is collapsed in the posterior area, and we need to open that up, and this is the time to do it, not just force weak compromised prosthetics to fit in a very, very tight spot. I mean, that to me, those things just fail ultimately, and we don't want to be part of having stuff that fails. So that's DENTA4 with application. Whether you've been to phase 1 or phase 2, This is marrying these two things together in real life. This could have been a bridge, you know. Maybe this just happened to be going to be a partial denture, but this could have been a precision attachment case with you know, keying off of these two cuspids, and then make ERA attachments. Same down here. This could have been a crown and bridge restorative case with implants. For whatever reason, the patient, maybe through because of financial reasons, they could only do an immediate denture, and that's fine. But we still work with the same principles. Level the plane of occlusion and find a healthy VDO that complements the jaw joint, airway, and the muscles always are happier. The patient will look more youthful when you open this up, and they'll breathe better, feel better, and ultimately the restorative will last longer.